So, ladies and gentlemen, very thanks for asking me to come and talk to you. I'm a clinician, I'm an orthopaedic surgeon, and I'm in full-time clinical practice, although not doing quite as much as I was doing with this new role I have, but I hope to be able to explain to you what we've been trying to do, not just in London, but also around the country, and the difference that I think it's actually going to make. Fine. So why orthopaedics? Because we are massive players in the game. The MSK budget is anywhere between 5 and 7 or 8 billion, depending on what you talk about it. And if you look at the 46 specialties there are in the provider side, in terms of orthopaedics, we represent 33% of the surgical workforce, and 26% of all surgical interventions now that we see are trauma and orthopaedic. So we are big players in the game, and it's not surprising when you know the population's aging, we're living longer, and obesity is a problem, and therefore people are going to wear their joints out much more. And if you just look at the National Joint Registry, you'll see the data set there that shows in 2004, the first report of the NJR was 47,000 entries in 1 year. Look at 2014, over 200,000 in 1 year. And then when you come to this side and look at the sheer volume of increased revisions that we're seeing, we've got a real problem on our hands if we're going to maintain this timely, effective care as we move forward. And London's a really good example of that, because if you look at London, we spend a total of 16 billion. 1 billion goes on primary care, 2 billion on mental health, and then the rest of it, 13 billion, is spent on the provider side in hospitals like myself. And so we are a significant part of the cost. And if we're going to play our part in driving forward the changes in austerity that we need to maintain the effective care for our patients, then we're clearly going to have to do things in a different way. And I just use this as an example. For those that you're not medical, this is a very arthritic hip replacement, a hip that needs a replacement. And so this patient had that implant, which we know should give you, on NICE guidance, a 95% survivorship assured at about 15 years. And the cost of that implant is about £650. But the surgeon that was doing that case decided to use that implant where that would have sufficed, and the cost of that implant is over £5,000. There is no evidence to show that using an implant of that cost, when we know that the cost we're paid for a hip replacement is £5,500, is actually going to give any better long-term survivorship or indeed better function for a patient than that one that's at £650. And so clearly the profession, and include myself in that, are going to have to change in the way we do things. And that was the background really to getting the report out in 2012 about getting it right first time. We then got £250,000 from the NHS England and the Secretary of State, and then we set about producing a unique data set for every single trust in the country. Now, whenever we went, people said, but Tim, the data's rubbish. Well, actually the data is not rubbish. By the time you lay on 12 different sets of data onto every individual trust, there may be some discrepancies around some of the heads data, although that's getting better, etc. But actually it tells a pretty good story. And so what we did, we produced this data set on every single trust in England, and then what we did is we sent them out their data and went to see them all. And I've been to every single hospital in England except for about 4. And as a result, we published this in 2015 about highlighted the problems of variation, procurement, loan kit costs, etc., and what we could do about it. So much so that since then, we've now looked at Wales. I did Scotland just before Christmas, just completed Northern Ireland, and we've been asked to do Southern Ireland in the summer of this year. And I have now visited over 243 hospitals, so I've seen all the excuses, I've seen all the bullshit, and no one actually now can actually tell me anything, because I've heard it all before. And the most important thing is we've met 1,900 consultants, and I've met over 600 senior managers, including medical directors and chief executives, and there is no doubt there is a real appetite now that we are going to see massive change, and indeed we have already done so. So on the background of the 250k we've spent, we've already got really good evidence to show that we've already saved over 60 million by just getting people to do things slightly differently and actually improve the quality of care, which is the crucial thing around this. So I'm just going to give some examples about how we can do things slightly different. So this is Manchester, and this is the 10 trusts in Manchester that we had all in the same room, and we wanted to know what their deep infection rate was in hip and knee replacement. That's all. Some trusts didn't know, and they scrabbled around to find the data. So Trust 9 here just didn't know what their data was. But the variation was from 0.19% to 4.49%. And I have to say there is a trust in London that when we went to see it had had a blip where its infection rate was 15%. Now I would suggest from family and friends testing, everybody in this room, you would not want your relative or your mum and dad or indeed yourself having a joint replacement in an institution like that. And why is this important? Because if you could reduce the infection rate across the country down to 0.2%, you're going to save at a stroke the NHS every year, just for hip and knee replacement, 250 to 300 million pounds, because it costs over 100,000 pounds to put right once it's infected. So it is an absolute no-brainer that this sort of information will drive the change. This is a funnel plot, and this is patients around, this is all the trusts in England, and I've highlighted just the ones in Manchester, and this is all trusts in England who are doing an arthroscopy where you put a telescope in the knee on patients who are over 60, who then come to having a knee replacement within a year of that arthroscopy. So you could say, why on earth are you doing that arthroscopy? Because if they're having a knee replacement within a year, the patient didn't really need that arthroscopy. And just look at the variation around England. And this is 1 and 2 standard deviations above the mean. And clearly, and we've seen a significant change since we've been round all those hospitals where people are now beginning to come back into line. But it's even worse than that, because when we went to Scotland, Scotland is in blue and we're in red. We have twice the arthroscopy rate for patients aged 60 to 74 that Scotland does. And we should be asking ourselves, indeed we are, why is there that such a difference? And something that we are going to have to address. Other variations we've found, litigation. No one really talks about litigation, but litigation is becoming unaffordable in the NHS. So in orthopaedics in 2003-04, we paid out £37 million in 1 year for litigation. You fast track forward to 2011-12 in 1 year, we paid out £187 million, and it's increasing at £30 to £4 million a year and is becoming unaffordable. And we broke it down to each hospital where we said, well, what's the average for every orthopaedic procedure? And it works out about £54. But we found some trusts where it was 0 and some trusts where it was £151 for every orthopaedic procedure. And what was interesting, that was a recurring theme. It was bad that year, it was bad the year before, and it was bad the year after, but no one discussed it. Managers and clinicians never got together to learn about it or to understand what was all going on. Cost of implants, my God, it was like the Wild West out there, and I'm going to show you some information. And loan kit costs, no one talks about loan kit costs. But the average when we went around was £200,000 in orthopaedics a year, with one trust at almost £1 million. And 30% of loan kits never used. So what on earth are we doing paying for loan kits, which would make significant savings? And of course, you all know, huge variation of implants chosen by consultants like myself, and we found a lot of evidence of surgeons having a go at low volume procedures. So, litigation. So this is again the 10 hospitals in Manchester, and I had to ask permission to put this data up. So this trust said no, so you just draw your own conclusions, all right, about what their outcome was like. But look at the variation. So you've got one trust here at £36 for every orthopaedic operation, and this one at £134.90. And we looked with the NHS Litigation Authority at all the 28 causes for litigation, and the top 4 were judgment, tissue damage, procedure, and unsatisfactory outcome, and actually they are all totally preventable. So why on earth have we got this massive variation? And it is something that we're going to address over the next 2 to 3 years. Low volumes of surgery. So going around all the hospitals in England, look at this. Unicondylar knee replacements, half knee replacements. The 75% of surgeons doing that in this country, in England, are doing 10 or less a year. The commonest number that was done by an orthopaedic surgeon in England is 1. Second commonest number is 2, and the third commonest number is 3. Now, not only will that produce an adverse outcome for the patient, none of you would go and see a surgeon doing that low volume, but the other thing you do is you get loan kit costs because you borrow the kit to put the implant in, you pay full market value for the implant, and that is just no longer acceptable. And then when you come down to revision knees, which are very expensive, as many of you will know. And on the whole, most surgeons and trusts pay full whack for those implants because the volumes done are low, because most surgeons, 81%, are doing less than 10 of those a year. And that is what we are going to change in terms of practice. And it's not just hip and knee. It's exactly the same with everything else. So this is elbow replacements, and that again is Manchester. 31 elbow replacements done in one hospital, the rest done by few and far between. Loan kit costs, full market value, and outcome for the patient nowhere near as good as that hospital. So since we've been there, all those elbow replacements now are done in that institution. And surgeons that want to continue to do that sort of work go to that institution to do it. But then if you look at London, this is shoulder replacements and revisions in London, when you've got one big centre, which happens to be where I work at the RNOH at Stanmore, other people doing a little bit, there's some down at Epsom St Helier. So why on earth are we all having a go at doing this? Why on earth aren't we getting our consultants onto, I want in London 5 or 6 sites to do the work, no loan kit costs, best value for the patient, best outcome for the patient, and actually with the negotiations you can get on this, the best value to the taxpayer. So something that we're going to do. And if you look around the country, most centres are doing only 6 shoulder replacements, 4 elbows, and ankle replacement, usually less than 2. And again, look at spinal fusions in London. So we've got the big centres here, you've got the small centres there. Why are we all having a go at this when actually we can do and we can change things much better? Now what we've got to do is we've got to get consultants who are not as enlightened as myself to use the evidence base. And the National Joint Registry is fantastic at providing that evidence. And it shows that in patients certainly over 68, if you have a cemented hip replacement, it will last you and it will do very well, and it's about 1/3 of the price of an uncemented implant. But we looked at the data in 2012 of what was going on in the NJR, and despite all that evidence, we put 22,000 plastic cups in, cost the taxpayer just over £6 million, but no, my colleagues like to put nice shiny metal things in, and we put 42,000 of those in with no evidence that actually they're a lot better than that, and that was £80 million for the taxpayer. So why on earth are we doing that? So we've got to change it. And if you look at around the country, so just using a cut-off of 65, if you're more than 65, a cemented hip replacement should last you a good 15 to 20 years. So that's blue. And then yellow is uncemented, which will last you, there's a higher early revision rate, but it will last you, but it's 3 times the cost, okay? And there's no evidence that it's better output for the patient. But look at the variation in one city and then at various institutions around the country, where blue is cemented and yellow is uncemented. Why have we got such variation? And it's something that we're going to have to deal with. So if you look at revision hip replacements, 61% of surgeons around the country are doing less than 11 of those a year. And you say to yourself, well, why is that relevant? Because it comes down to what you pay for your implants. So if you just look at routine hip replacements, the variation, that's a cemented hip replacement, which is a polyethylene liner, a metal head and a metal stem. The variation is, the minimum price we found is £438, maximum price £4,902. What is going on out there? You come to ceramic on poly, minimum price £500, maximum price £3,872. And I was sent an email, I think 2 days ago, saying that someone asked about procurement, and they spoke to the implant companies that you couldn't get that price unless it was a pre-entry level, and the implant companies would never sell it to you for that. Well, that's absolute nonsense. That price has been accrued by Basingstoke, and I was there yesterday, and if you want to find how they've done it, the guy there is Jonathan Hobby, and that's how you drive the interface and the arguments with the implant companies. But then when you come to revision implants, and we all pay way too much for those, this is an anonymised trust. They're doing 84 revisions a year, and what they found is 33% of those surgeons doing those revisions are doing less than 5 a year. And guess what? They're doing way small numbers, different implant companies, and we've called it band 1 and band 2. There's 12 bands, and actually band 1 and 2 are the most expensive, and they're paying through the nose for their implants. Not only that, their results will not be as good because the low revision rates if you're doing low numbers, then your outcomes will not be as good. So clearly, something we've got to do about it. And then when you come to spinal surgery, and I don't want you to know about procurement, it really is like the Wild West out there. So I've just used an example of north of the country. So there's the river, there's North Tees, and there's South Tees, which is Middlesbrough. This population is just over 226,000. This population is 500,000, okay? So when you look at their data and their spinal data, how come that North Tees, which has half the population of South Tees, is doing 3 times as many injections which have no evidence? And then when it comes to spinal fusions and using metalwork, they're doing almost twice the number, and yet they've got half the population. Well, that is just absolutely crazy, but no one has shed a light on it until we have over this project. And what was interesting is the CCGs had mandated 5 years ago that all spinal surgical data should be inputted into the National Spinal Registry. To date, only 15% of the data has, and a lot of this work doesn't really stack up in that is best value for money, and that actually improves patient outcomes. And then when you look at procurement of metal implants that go in the spine, the cost and the variation is just truly unbelievable. So you can pay for a rod anywhere between £70 to over £1,000. And so we looked at our data at the Royal National Orthopaedic Hospital, and this was our historic data. We have the largest scoliosis unit in Europe, and we have about 9 surgeons, and they did use 5 different sets of implants. So what we did, what you don't want to do with these implant companies is get involved in what's a screw and how much you're going to charge me for that, what you're going to charge me for a washer, what you're going to charge me for a rod and things like that. Don't do that. What you want is per construct, because then that tells you what you need in your totality when you're negotiating. So our surgeons were using 5 different suppliers, right? And look at the variation. So to get a 6-level fusion, which is like sorting out a crooked spine, we were paying anywhere between 3,200 and 6,700, but then when you add the VAT, it's 3,800 to 8,100. And it was the same with the constructs, whatever you used. And since then, we've negotiated down and we've saved 40% on our costs of our spinal implants. And so clearly, we've all got to really do the same. So what the GIRF pilot showed us is that there's huge variation, and there is no doubt there's a lot of scope to tackle that. And there are examples of really good practice out there, like the LPP really trying to drive down costs, Basingstoke as a unit driving down the cost of hip and knee replacements, as well as shoulders, elbows and ankles. And the answers really are there. And what we've got to do is use those, cascade that out, and get those out into the wider NHS. But where there's no consensus about what is best practice, then we as clinicians have to actually provide that. And so what I want to see happening across the country is networks or hub and spoke. I want about 30 or 40 of those around the country doing complex orthopedics. And what we want to do is set the standards, talk about implants, loan kit costs. 90% of those costs have got to go in the next 2 years. We've got to make real inroads into our costs of our prostheses, etc. And that will all be about improving quality, training, and actually maintaining timely care for our patients. Now, we already know that there's a vascular network out there, and we know that that can actually work really well. In London, we've got the stroke network, which I think has been a real added advantage. So networks are the answer, and they will work improving outcomes and also controlling costs. Now, everybody says to me, Tim, well, where should our networks be? Are you going to designate them? I don't think I should have to do that. I know what I want in London. I want 5 or 6 units doing the complex work, and I think everybody's signed up to that. But the networks will vary depending on the location and also the geography. So if you look at Leicester, really quite straightforward. Put all the consultants on one site, 33 of them, 7 ring-fenced orthopaedic theatres, 3 ring-fenced wards. They are as happy as Larry. And everybody says to me that orthopaedic surgeons are difficult. They're not difficult. Most of them have run really busy clinics. They want to work really hard in the operating theatre. They just want things to work well. So what we've got to do is give the guys the tools and the ladies the tools to do the job, and actually an environment that actually rewards that, where we can get through the work and do it well. But they've got to stand up to the plate and realise that the sea is changing, and they may not be able to do what they want and the cost of the implant what they want, and they're going to have to change. But in Nottingham, they've got a different model, where they're working with the Pilgrim Hospital and Lincolnshire to bring the revisions in if they need to do that. So clearly, everything there will move forward. So in orthopaedics, what we're going to see is in the short, medium, long term, we're going to see a significant reduction in all of those. And if we just do 4 things, change implant costs for hip and knee replacement, or sort out infection rates, sort out 50% of litigation and eliminate loan kits, that's 2 billion of savings over 5 years just doing those 4 simple things. And that's without looking at spines, shoulders, elbows, etc. To implement it, which we've got the backing of the government now to do, is we need the support from the specialist associations. And everybody, all the colleges, all the associations across the piece are all signed up now to this programme. And the government have now given us £2.5 million to implement orthopaedics and use the same data and the same methodology to look at all the other surgical specialties. And what I'm doing at the moment, we're rerunning their data set. We're going to revisit the bottom 25% and the top 25% and then put them in touch how we can change that. And we've had a lot of support from the colleagues. Now, what's going to change and drive the agenda is the dashboard. And that is going live in orthopaedics on every provider trust in England at the end of this month. And we're part of Patrick Carter's model hospital. And what it will also do is link into the same categories as the CQC. There's 6 domains. And that is going to drive the agenda. So we can look at what is effective care. The CQC will be able to look at that. That's the average for hospitals. That's where the hospital sits. You don't want to be anywhere near red or orange. And then the CQC will be able to review those and say, what sort of targeted visits do we need to make? And whether it be effective or responsive care, they will actually be able to look at the reds and say, we need to go to that trust and look at what you're doing. And that's going to produce the clinically led catalyst, which is going to improve quality, maintain timely care, and make sure we deliver best value for the health service. And just to finish, so we've given £2.5 million to do all of those. I've now appointed 10 clinical leads who will work underneath to me to drive this agenda. We're appointing the last one, cardiothoracic, next Wednesday. But David Williams, the Director General of Finance in the NHS, called me to his office only 2 weeks ago, and they've now given me 56.48 million to do it, not just in the surgical specialties, but we're going to do it in all the medical specialties. And that will include procurement across all those. So will we be empowered to deliver? Absolutely. So Carter's report, he told me that we are the backbone. We are the clinical delivery of Carter, and actually will help NHSI, I think, deliver what we need to do. And we've been told that we can now hold trust boards to account and also medical directors. And Patrick and I had to go down to Headley Court last week, and we were in the car. He said, now, Tim, he said, the way you do this is quite simple. He said, you go out to all these hospitals, you reward the ones that are really good. He said, then you find a couple of crap. He said, then you sack a few people, and then it will all change. And that is exactly what we are going to do, I have to say. But I just thought the way he said it was just brilliant, actually. So that's what we're going to do. So clinicians are the key here, all right? You can't do it without clinicians, and clinicians know this is coming. They're aware of what we're doing, and they have got to stand up to the plate. We've got to have clinicians and managers working very much more, what I say, shoulder to shoulder, to deliver the change. We need to re-empower them in the right environment to do the job well. We've got to get back, by working well, the £1.2 billion that NHS money goes to AQP. If we're going to survive, we've got to be good enough to compete for that work, which means clinicians have got to increase their productivity, their efficiency, and they've got to do the work at best price and get best value. And part of that will be procurement. So we've got to stand up to the plate, and I think clinicians out there are willing to do so. Thank you very much indeed.
Some serious food for